Good evening. Hello. We are back with I Care for Your Brain with me, neuropsychologist Dr. Karen Sullivan. And every other Wednesday, we give you a free evidence-based brain health lecture. Tonight, our topic is menopause and memory. This is a topic I have wanted to research for years and decided I would commit myself to doing the research for this lecture because I have had so many women coming into my practice complaining, concerned, worried that memory is changing, worried that they are having mood issues, worried that no one is understanding what is going on with them, worried that they're going crazy. And when I was in grad school about 9-10 years ago, there really wasn't that much science-based evidence to guide conversations like this. So I knew that in these last 10 years that some research has finally been put forward. So I wanted to commit myself over the last few weeks to gathering some really good references and giving it to you guys on our show. So this is important for individuals. It's also important for women in general as a population. By next year, 2020, there will be more than 50 million women in the United States alone who are older than the age of the most common onset of menopause, which is 51 years old. This is so interesting if you compare what we know about women and hormones and their health to what we know about men. So you can hardly read a men's health magazine these days without hearing the term low T. We know a ton about the prostate, and it's just very interesting to me on kind of a medical, sociological level that we're finally getting to the point where we're really understanding that women and men are different in hormonal ways and that these differences have a big impact on the brain and cognition. We have been talking for so long in the world of neuropsychology about cognitive differences between men and women, and part of it is their kind of media runaway stories, right? So men are good at math and women are better at interpersonal communication and emotions. But the truth is a lot of that is false. That's not true. And it really doesn't matter. What's important in science is that we actually turn to health disparities, the differences in outcomes for men and women based on their hormonal profiles that actually matter. So a perfect example is we now know that heart disease different in women. We also know that estrogen probably has a pretty big influence on Alzheimer's disease, which is probably why so many more women get it than men. So menopause is just another example of the fact that we're very, very late to the game indeed. So as I was doing my research for all of us tonight, there were multiple articles that would conclude with this basic quote, and I wanted to start off by telling you this tonight. So this is papers from 2018, 2017, even this year, saying things like most primary care residency programs in the United States do not provide adequate education in women's health in general, but specifically the impact of menopause and its management specifically in particular. So it's often referred to as an unsolved puzzle. There's too many pieces to really be able to appreciate what happens to a person or a brain when all the different influences of menopause come together. But there certainly have been advances, and that's what I want to focus on with you tonight. So if you are lucky enough to live long enough, menopause will be a natural part of your life. It's defined as not menstruating for at least 1 year due to ovulation stopping. So ovulation, as many of us know, is when a mature egg is released from the ovary, pushed down the fallopian tube, and is made available to be fertilized. If it is not fertilized, the egg disintegrates, breaks apart, and this is when women get their period about 11 to 16 days later. There are many factors that influence the age at which menopause starts. So even things like how you grew as an infant, if you smoked at all during your lifetime, your overall socioeconomic status, and if you breastfed a child. All of these things can make your time of menopause either later in life or earlier. It's considered to be a highly genetic issue, meaning that if you look at twin studies, most twins get their period of menopause, about 40 to 70% of them have it within the same few months So what they say is if you're able to ask your mom or a very close sibling when they started the process of menopause, chances are, a half to 3/4 of the time, that will be around the same time that you start as well. Menopause is a biological transition that can either happen slowly over time, naturally, or abruptly if the ovaries have to be removed. So the most common reason for ovary removal is related to cancer, the identification of precancerous cells, ovarian cysts, endometriosis, these kind of things. When menopause happens naturally, it is typically thought to be an 8 to 10 year process. And what was fascinating to me is that the step down in hormones that happens is not gradual. It is not what we call a stepwise decline, meaning you can kind of imagine a set of stairs where it's kind of a plateau and then it goes down and a plateau again. It is actually all over the place. There is so much variability. Even if you were to go and get your blood taken at 10 o'clock in the morning, by 5 o'clock that afternoon, your hormones could actually be completely different. This is part of the missing piece that so many of us are chasing because we can't even get decent lab values that represent the overall picture of our hormones. So even within an hour, we can have dramatic decreases and increases. When we're talking about menopause, of course, we're really talking about hormones. So the menopause hormones are called steroids, and they include the big players of estrogen, progesterone, testosterone. But within each of those categories, there are many sub-hormones. So this is where the complexity comes in because it's very hard to know, it's very complicated, how one hormone affects the other. So as many researchers say, 1 + 1 does not equal 2. Hormones interact with other hormones, which then have a feedback loop back to the original hormone, which then affects the previous hormone. It is unbelievably complicated. The most research has been done on estrogen, and we consider this to be the master regulator of the metabolic system in women. And so within estrogen that is made within our bodies, we have, of course, estradiol. This is the most common one that's found in most birth control pills, but we also have estrone and estrol. So even just saying the word estrogen, we actually already have 3 hormones that we're really dealing with and not just one. Hormone systems are very similar to neurotransmitter systems in the brain, which, like I just said a minute ago, very subtle changes in one has a cascade effect on another, which then can have a modulatory effect back to the original one. It's kind of like a moving target. We do know some specific things, though, about specific hormones. So we know that when estrogen is high, that women can have things like heavy bleeding, bloating, breast tenderness. We know that when it's low, this is when the symptoms of hot flashes, night sweats, heart palpitations, headaches, insomnia, fatigue, and bone loss are the most common. We know that when progesterone goes down, and this is the most common hormonal dip that happens in perimenopausal women, this is where we get the irregular periods. So we can have longer periods, we can have heavier periods. We really don't know the impact of low testosterone on women, and that is absolutely fascinating to me because I think we have been oversaturated by media accounts of low T in men. Many men that come in to see me who are in their 40s and their 50s, their thing, they write down on my piece of paper when I say, how will this neuropsychological evaluation help you? They want to talk about low T. They want to know how to get a prescription for low T. It's almost a little bit of mass hysteria. I think it's fascinating that we know very little about low T in women, yet of course we also have testosterone in our body. So testosterone levels in women that are lower than 20 over the age of 50 are what we consider to be low. So the little bit we do know about it is that this is what's really impacting women struggling to feel like they have a libido that they're happy with. This is where the depressed mood often comes in, things like lethargy, muscle weakness. And like I said, it's very hard to get a read on testosterone because of the fluctuations that happen even within a given day. So when we talk about menopause and menopausal symptoms, there's 34 symptoms that scientists go by. The most common are the insomnia, mood swings, fatigue, depression, irritability, racing heart, headaches, changes, and then the two biggies are the hot flashes and the night sweats. So during the later stages of perimenopause, the research suggests that almost 75% of women say that they have hot flashes or night sweats to the degree that they consider them to be moderate or severe, and that these go on for almost a decade, which, as someone who's staring down the barrel of perimenopause, I can tell you that is a scary situation to think that for 10 long years this could be going on. Estrogen regulates many biological systems. So this includes thermoregulation. This is why it's so related to the feeling of being hot. Estrogen regulates sleep. It regulates the circadian rhythm. It regulates mood, and drumroll please, it regulates different aspects of the brain. There are specific receptors that are in the brain that are just for estrogen and are just for progesterone. So a receptor is kind of like a specialized lock, and the only key that will open that lock is estrogen. So there are certain functions of the brain that have a really hard time happening if you don't have that specific hormone of estrogen to open up that lock. So what we know is that low or no estrogen impacts the structure, the function, and the chemical firing of the brain. You ready? So that's 3 effects, both directly and indirectly. So now we've got 5 interacting factors, and we, the women, are in the middle of all these different crazy things. So no wonder women tell me they feel like they can't make heads or tails of their symptoms. It's never the same. I think I have a solution for one problem, and then I am over here trying to fight another fire. It really is all over the place. So when we talk about the structure of the brain, this is actually the brain matter, the gray matter, the white matter. This is actually, if you looked at an MRI scan or under a microscope, you would actually be able to see the structural makeup of the brain. So when we just think about that, if you look at animal models, right, which is how brain science is largely conducted, estrogen loss is accompanied by reductions in dendrites in specific part of the brain. So a dendrite is basically a little tail, a projection off of a neuron, so a specialized cell in the brain, that receives signals or information from other brain cells. So it's basically the bridge between multiple brain cells. It's how information gets moved from one part of the brain to another. We also know that some parts of the brain, in terms of function, which is what the brain actually does, so how it thinks, how it feels, is related to estrogen, very reliant on estrogen. So these are mostly the memory centers of the brain, the medial temporal lobes, and also something called the posterior cingulate. And what that part of the brain does is it actually mediates or kind of negotiates between memory and emotion, specifically calling up positive emotions from the past. And I think that is very interesting when you start to think about some symptoms of menopause and people talking about being irritable or maybe depressed. There may be a biological reason that we are literally having a hard time calling up the good things that have happened to us in relationships or maybe at a job. Neurochemically, we also know that estrogen impacts other neurotransmitters, namely serotonin. As you all know, when serotonin is low, it is very hard to have a positive mood. So indirectly, we know that some of the symptoms of menopause have a trickle-down effect on brain function. So let's just take the classic example of hot flashes. So hot flashes often disrupt sleep, and that alone can cause mood symptoms. When people don't sleep very well, they very quickly become irritable. If they don't sleep very well for a longer period of time, they then become very forgetful and have a hard time paying attention. So just that in and of itself can have that indirect impact on memory. But we also know that things like people not validating what we're going through, people, making snarky comments about that time of the month. I mean, those things are genuinely annoying. And over time, you're probably going to become a little bit irritable about those things. So I think it's important to recognize there is a social or a cultural piece to this too. So now we're going to talk about memory, the reason that you're here. This is our specific purpose in being together tonight. So I would love to hear from any of you right now who have been through menopause or going through it, if you think that your memory has been affected by this experience. If you say yes, you are actually in the majority of women. So anywhere up to 62% of women who've gone through menopause say that they believe that their memory changed around that same time. What is so cool to know is that this used to be considered a subjective symptom. And what does subjective really mean in the world of science? It's a little bit of a judgmental term, which basically means you think it's happening to you, but we don't have any objective evidence that it's happening to you. Kind of a little bit like it's in your mind. I'm so happy to tell you that in the last 2 to 3 years in neuroscience research, it is now considered to be an objective symptom of menopause. So we now actually have scientific evidence that memory symptoms are not just the indirect effects. It's not just sleep. It's not just depression. It's not just irritability. It is literally a bona fide straight impact on memory. So this is awesome. However, the fight for validation still exists for 2 main reasons. The first one is, like I said, the lab studies are so tough in menopause. There's also the impact of many people will have low hormones, low estrogen, but they don't necessarily have enough time hasn't gone by to actually have a hot flash or to have a period be skipped or to stop their period altogether. So sometimes they don't even think, oh, this is a perimenopause thing. They're just starting to go downhill a little bit with a specific type of memory loss that I'm going to explain in a minute. So they don't even understand. The other problem is if our medical doctors don't understand menopause well, I am very worried, and this is something that's been written about in the literature, that we are getting misdiagnosed as women, and it actually goes in both directions. So most of the research literature talks about the fact that someone can become very worried about memory, the doctor doesn't know very much about menopause, and they get diagnosed with a dementia when they actually don't have a dementia at all. I've actually had the opposite experience, and one that really stands out in my mind that I'll never ever forget, which was a woman in her late 40s, early 50s, that came to me after being diagnosed with what the psychiatrist called malignant menopause, which that title alone is very sexist. And after our evaluation here in my office, it was very clear to me that she actually did have frontotemporal dementia. And the problem is that she was actually released from her job, virtually fired, and was denied her pension because her diagnosis was malignant menopause. And so I worked with her family to restore her pension, and I'm very proud to tell you that we were able to do that successfully for her. Unfortunately, she passed away about 1.5 years after we properly diagnosed her with frontotemporal dementia. So the truth is she and her family lost about a year and a half of not actually knowing what was going on with her because the psychiatrist insisted that it was menopause when it definitely was not. So this is yet another reason that you should know about neuropsychology. You should advocate for a neuropsychological evaluation because bedside screens aren't going to do it. Some physicians are better than others, but the truth is a neuropsychologist is your expert in brain and behavior. If you're worried that something up here is affecting you as a person or your memory, we are the kind of doctors that you need to see. So when we say memory loss, this actually gets very complicated because there are many elements of memory. It is really not as easy as I have a good memory or I have a bad memory. If we did a little chart here, you would be able to see many different boxes and it would have many high-level cognitive words. The only thing we need to know for the purposes of our talk tonight is that there's one kind of memory that has been shown to be specifically impacted in menopause, and that is something called working memory. So what is working memory? It is the short-term storage and control system in the brain that basically helps us hold on to information and manipulate it over a relatively short period of time. So this is like if somebody yells a phone number to you across the room and you're rushing to write it down and you're kind of rehearsing it. This is when you go to the grocery store and someone told you a list of 5 things to get. It's not something that's important to remember 1 to 2 years, 5 years down the road, so you don't necessarily put it into long-term memory. It's almost like a scratch pad, they sometimes call it, in your brain. And it's related to your prefrontal cortexes right here in the front of your brain. It's actually one of the big cognitive challenges in attention deficit hyperactivity disorder. And I think this is a very important point. If you are going through this right now, you might start to feel like I have ADD, like I'm all over the place. I can't keep things in my memory. It's not ADD if you haven't had it, since childhood. It's very important for you to research the possibility that it could be related to hormones. So if you look at women who have poor working memory performance on scientific studies and you correlate it back to their estrogen, the lower the estrogen, the lower the performance on the working memory scale. So I think this begs the question of, well, what are we going to do about it? And that's kind of how I organize all my talks. I like to educate you and hopefully entertain you to some degree with information that I think is fascinating, but really what I care about is the practical application of the information. So to me, the natural question was, well, what about hormone therapy? How does hormone therapy relate to memory concerns? Once again, I'm going to tell you, it's very complicated, but I will say a few things. The first thing is that not nearly enough women seem to be getting treatment. Of course, there was a big concern about HRT, hormone replacement therapy, years ago as it related to increasing the risk of certain estrogen-dependent cancers like breast cancer and ovarian cancer. And the truth is, I'm not super up to date on HRT, but what I can tell you is that when menopausal symptoms go untreated, they are dramatically associated with higher healthcare costs and lower work productivity. So it behooves governments to try to fund these type of research projects because your workforce is aging and your workforce is not able to work efficiently because of some of the hormonal changes that are going on. So interestingly enough, there's something called the North American Menopause Society, and they do recommend hormone therapy, but only for women who are going into menopause after surgical menopause. So they actually don't recommend it for any women that enter natural menopause, okay? And further, they say that they do not recommend hormone therapy at any age to prevent or treat a decline in cognitive functioning or dementia. Although they do say that HT is really good for hot flashes and sleep disturbance, and they hope that that has an indirect effect on memory and concentration. The most recent good quality study I read about this came out late last year, and it was a study of nearly 100 healthy postmenopausal women who did not have any other health conditions, okay? They were put on estrogen replacement. They performed significantly better than women who were very similar to them who had not had any type of estrogen replacement. So what was cool about that is that the positive effect was not just on memory broadly, it was really focused on that working memory, that scratch pad in your mind when you're trying to remember something quickly and on the fly. So there's really no medication treatment. I think what's important, as always, is to educate yourself, advocate for yourself, identify medical providers who are progressive and who want to hear your side of the story, who respect your expertise. And I hope after this lecture tonight, you maybe feel a little bit less crazy, because it's kind of a recipe for feeling like you're either out of control or when you try to explain it to people, they just really don't get it. So there's a couple things I can recommend to you, bringing in other aspects of brain research about how to improve working memory if this is something you are struggling with. So within memory aids, we think of it in two ways. We have internal strategies, which are things we can do in our own mind when we know better, and external strategies. So these are things you can actually do outside of yourself, like write things down. So within the world of internal memory cues, I want you to just think about rehearsal, meaning saying something over and over and over and over again until you drill it into your memory. A lot of you do this naturally as a way of compensating because it just makes sense and it works. The other thing is to visualize what you're trying to remember. So we know that the human brain recalls information much better if it is emotional and personal. So try to bring yourself into what you're trying to remember. And you also want to be able to rely on shortcuts, things like mnemonics. Many of us can remember something if we can put it into some kind of, Roy G. Biv. I mean, so that's how we learned the Great Lakes, right? The colors of the rainbow. So if we just take something like the example of a grocery list, an internal strategy might be something like putting all the words together and making some kind of a story in your mind that relates back to your personal history that will help you recall it. Of course, you can also write it down, do a voice memo, ask someone else to remind you, say to someone, I'm going to go to the store, have your phone on you so that way if I need to call to get a reminder. Some of those things seem so obvious, but people are hesitant to do them, especially if they've had a good memory before, especially if they're very intelligent. They don't have any coping skills for asking for help with things like remembering a grocery list. But the truth is, if you can get over the ego part of asking for help, it keeps your function going longer than if you just decide, well, I'm just going to forget what I need at the store because I don't want to have to ask anyone, okay? The other thing, of course, are things like making sure your sleep hygiene, your sleep quality is as good as it can possibly be. Aerobic exercise has been shown to improve working memory. And of course, looking at things like mood, your diet, chronic pain, self-care, your level of stress, all of the things that we know support a good memory system in general. When I am back next Wednesday, I'm actually going to be offering you a specific lecture on memory that I did a little while ago, where we went and we taped some lectures in a studio. It's a little bit of a different feel than what we do here. So I'll be talking about that next week. But I hope, this is what is my sincere wish in my heart, that this lecture helped you understand menopause a little bit more, helped validate anything that you or a loved one might be going through, and help maybe give you some direction on how to make it better. But if you feel like you still need more information or you need a personal approach to your own issues, by all means, seek out a neuropsychologist. You can send us a message here on the Facebook page and say, this is where I live, here's my zip code. We will personally write back to you and recommend someone to you in your area. Please share this if you think that it is worthwhile and other people would appreciate it and learn from it, and type in and let us know what you think. I'm just here, alone in my room putting this out there into the world. So it's critical for me to know that you're here and that you listen and that you got something out of it. I will be back in 2 weeks with a brand new lecture, and I'm actually going to do the topic of vestibular neuritis. And this was sent in to me by a woman who follows us named Ashley, whose very good friend has just been diagnosed with it. It is one of the main causes of dizziness and poor balance. So I'm going to be taking a dive into that topic in 2 weeks. So if you're someone who struggles with balance, it would be an important one to listen to. So thank you guys so much for being here. I have missed doing these more in-depth lectures. I'm really glad I did it. I'm really glad someone recommended that I do it. And I learned a whole lot, and I really feel like I can serve my patients better, my women patients better, having known this information. So it was good for me too. I'll see you guys next time. Bye-bye.